Dear colleagues, today we're going to talk about the Canon Xephilio A1 OCT machine in my everyday practice of a vitreoretinal surgeon. These are my disclosures regarding to the presentation, and this is our first case which I want to present. This is a case after a silicone removal. We suddenly experienced a sudden drop of vision in the central area, and the patient was describing scotoma in the center. So we were able to image with the OCT some issues with the outer nuclear and outer plexiform layers, and we concluded, or we found that something is wrong there. And what is wrong? When we have a good M-phase imaging, meaning that the machine is capable of high-density raster scans, and it obviously does it pretty well, we can segment all the layers in a custom level where we can find certain wave pattern. This is, at least for me, the first time to depict with a machine examination the changes in acute paramacular middle layer maculopathy. So you can also appreciate the thickness map where we can suppose that there is an edema here, and it is quite correctly superimposed over the anatomical findings. So the level of precision of image taking of the Canon equipment is absolutely stunning here. Here you can see another layout and another printout, if you want to say, where you can compare simultaneously the OCTA image, the M-phase image, the thickness map, and also you can see where actually you are in the image. So it's quite useful for a fast orientation during the process of the diagnosis of the situation. So as I said, this is an early PAM situation. Here we can appreciate how this situation might evolve in the time, and this is where OCTA comes really useful, and we can see where the ischemic event happened, because there is an assumption that PAM pathology is ischemia related in the capillary circles of the retina. So purely in terms of how we understand a disease and to show this disease on the patient is absolutely indispensable too. Here you can see a larger image of the OCTA, which is segmented exactly on the area where this problem occurred, and we can be certain that there is no vessels there. Is there ischemia or is there a perfusion? We cannot know, but vessels are not there, so they probably are empty. Another image where we can appreciate the changes of the outer plexiform layer here. This one, this pattern, wavy pattern, is something which is not normally seen on the retina. Again, courtesy to the high density M-phase mode that we can utilize here. Also, you can see acute macular neuropathy, which is another, I would call it borderline diagnosis, because we can assume that this is the diagnosis, but up to now we cannot really show it to the patient, and we cannot really see it with regular OCT line scans, for example. But here again, the OCTA and the M-phase combined together somehow extracts more data for us. And even the thickness map here shows non-perfusion in the center. We know that we have a vascular area of the foveola, but here it coincides with a scotoma. And when we go deeper into the layers of the retina, we suddenly find broader area of vascular disturbances. So our assumption for acute macular neuropathy can be somehow backed up by these images. So this is another interesting thing. We can, albeit we have a detached retina, to try and achieve a really good OCT scans in order to show to the patient exactly what is the disease from which he is suffering. Later on, we can show the result after the surgery through a silicone tamponade, which is quite good we know that the silicone is with different refractive index and sometimes might be difficult even for fundus cameras and OCT devices to penetrate and correctly depict the data which is gathered from them. But these images are quite nice here. This is another picture of the fundus tamponade with silicone, and we can appreciate where the silicone doesn't tamponade the retina. In the previously bursa prepapillaris area, which is not here already, but still we can see why the silicone cannot be fully utilized in macular hole surgery, because simply it doesn't tamponade the macula. And this is infrared imaging from the A1, and it is quite helpful for our understanding how we interpret the findings in the eye. Also here, we can again see some problems here, lack of integrity of the outer plexiform and outer nuclear layer. And also I want to emphasize on the choroidal imaging. This is a system which utilizes, if I'm not mistaken, 890 nanometers light source, which is with more depth penetration compared to the classic 780 nanometers OCT systems that were available up to now. So we have a good choroidal imaging also here up to the sclera actually. So again, these are problems, ischemic ones, in the border of outer nuclear and outer plexiform area. So again, something like PAM or IMN, which is basically one of the major problems after a good vitreoretinal surgery. I have patients with retinal detachment. I have enough tamponade. I remove the silicone. During the tamponade, the patient is with 0.7, 0.6, or something functional, really good as a result. I remove the silicone, and on the next day or a week later, when the air is reabsorbed, the patient says, "Oh, I don't see. I have a spot." We call it scotoma, but it is like a blind spot in the center of the eye, and we are like only like that. I don't know what happens. Now I can show to the patient that there is anatomical and vascular problem which is not directly related to my surgery, and this is a vascular incident which might happen at any time. So with the help of the capabilities of the Canon A1, it makes me a better medical practitioner, because I can be trustworthy. Otherwise, if I cannot explain to the patient what actually is happening, he might think that I try to fool him around just to back him up from me and to abandon him. No, I see where is the problem. Even I can take action for that. I can prescribe fraxiparine and other things, but sadly, these are situations where there is no consensus of how and if we treat them and if we're going to succeed with this treatment. So just to let you know that these are rare conditions, but the ability to capture them with the Canon is exceptional. Again, a thickness map that you might see, and it is quite useful. And here in the menu, you have all the abilities to play with the contrast, to custom change the borders of your M-face slab, meaning that you can see wherever you want as long as you have enough density of your M-face scans. And you have plenty of them because this is an OCTA machine. What is OCTA imaging? OCTA imaging is tissue subtraction from high density 3D scans. So as much as more density you have in the M-face scan, the better image data will be here and will provide us with better diagnostic abilities. This is something amazing here. You can compare this fundus and this fundus. What is wrong here? Here we have gas, and normally with, at least in my experience, with previous systems, we weren't able on the first post-operative surgical day to visualize what we did with the macular hole, because the eye was filled with gas. And at least me, I have experience with Heidelberg, OptoView, Zeiss, somehow I didn't manage to get such images. First time which I got this, I thought, okay, it's an eye, it's a luck, it's something that luckily coincides in a good image. But then what happened? We had additional ones, and continuously we started to implement in our workflow first day post-operative OCT in gas-filled eyes with Canon. Of course, this cannot happen automatically. I will explain later how it can be achieved. Here, what is important is to see the flap. This is a good end-face image. The technique that I used to close the previous macular hole, this one was temporal ILM flap, and you can see it clearly where it sits, how it sits, because it might create secondary epiretinal membrane. And do we need to do something about it, or we just follow up? So a lot of things. When we see more, we work better. Again, the same flap, but enlarged. Another macular hole. Again, fundus and bad fundus. Why? Because we have gas inside. And when we have gas inside, we cannot image it. And you can imagine the emotional moment for the patient, because on the first day, we remove the patch and the patient doesn't see anything because there is gas in the eye. And when we are able to image his problem, this is your yesterday macula, this is your macula today, and the patient suddenly becomes relieved, and he starts to believe that everything went well and the surgery was successful, which is a really powerful message from the surgeon and from the equipment, because as transparent we are, better the trust is that we build in between us and the patients. Another case, again gas-filled eye. Here I have ILM envelope technique because this is a long-standing large macular hole, I would say huge macular hole. And again, on the first day during the OCT, we are able to see how our envelope sits. This is the layer of the gas bubble here and here. So a lot of things can be seen, and I perceive that as extremely beneficial for me as a vitreoretinal surgeon. Another case, again macular hole, and here this is a partially gas-filled eye. My main point here is that in macular hole surgery, if you are able to show to the patient every stage of his treatment journey, it is beneficial for him and also beneficial for us, because we know that nowadays we are trying a bunch of different techniques to close the macular hole, from classic ILM peeling through certain types of ILM flap, ILM envelopes, even retinal autografts. And for us, it's important to see which method works best in my hand. So the only way to do it is to check it early after the surgery with OCT. Again, the OCTA imaging here simply depicts the high density data that we have here, and here we can show the flap, how it sits, how it's flattened, and if the macular hole is closed. This is a larger image of the same thing. Another important thing, why we switched from classical ILM peeling to temporal ILM peeling. What is the basic need behind that? Do you see these holes here, 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 and here? These are defects of the RNFL. And if we peel it here like we used to do, we induced a RNFL defect in the papillomacular bundle, which might explain suboptimal functional result after the surgery. So the macular hole is closed, but the vision is around 0.4. Why? Because we damaged the RNFL. So a lot of details can be precisely evaluated when you have good imaging. This is an image of subhyaloid hemorrhagic collection. This is due to RAM or PCV, and what I want to show is the penetration of the wavelength. This here is clearly blood, but we can see here, which will give us the level of the blood penetration, and it will guide us on how we can deal with this situation. In that case, it was conservative and it resolved by itself. So if I'm able to scan this every week, I will titrate my approach from conservative to surgical or however I want it. But the main point here is that we have enough penetration even through blood. And you can see when it's partially resorbed, how the image is seen. And this is another case where you can really see well a detached retina. You can imagine that the detached retina is somewhere in the middle of the eye and it is mobile. So you need to use the manual mode of finding the retina and fine-tuning the image. But it's important because sometimes we are surprised by retinal detachments with macular holes. Sometimes the BUA is over the macula and we cannot see it preoperatively. If we can have this image and here there is a macular hole, it might completely change our surgical approach and also our communication to the patient, what to expect after the surgery. Because it's one thing to have a, let's say, classic rhegmatogenous retinal detachment, and completely the other if it is with macular hole, because it changes the strategy. And here is one of such cases with retinal autograft. This is a beautiful piece of peripheral retina transplanted over a huge macular hole. So it is also a good thing to be able to show to the patient that you did the impossible to save his eye. Because retinal autograft is something not really traditional, but it's here and it can be done and it can be imaged. So this is the size of the graft. It's a huge one, but it is really complicated case with a large retinotomy and really nasty PVR. So it was last resort for this eye. Again, this is even OCTA imaging in this eye, which doesn't have a central fixation because of the hole, and anyways correctly depicts that there are no vessels in the graft and there are superficial vessels which can be detected even through the silicone which is there. And basically that's it. Thank you for your attention.